I want to welcome everyone tonight. We'll get started. We're just a couple minutes off the schedule here. But we appreciate everyone coming to the County Commissioner Advisory Council tonight. Michael Lavender, if you haven't met me before, I apologize for my informality. I came straight from the office today. This is the way I was dressed. And I see that some of you went home and put your preaching clothes on before you came. But we're glad you're here. We're going to start by going around the room and letting folks introduce themselves, because some of you are new to us, or we haven't seen you in a long time. Just refresh our memories. And if you don't care, as you give us your name, please let us know which county you're from so we can kind of situate you in our mind to what area you're from.
Could I do one thing?
Yes.
Let me give this to Ryan so she can take it to you.
Oh, and that's also going to help them take roles. Take attendance. So, we'll start here.
My name is Nathan Bennett. I'm the Yancey County Manager.
Jim Edwards, County Commissioner, Yancey County. Ira Dowd, and I'm the Haywood County Manager.
Bill Upton, Commissioner, Haywood County.
Bill Eckler, Commissioner, Rutherford County.
Colonel Clausen, County Manager, Rutherford County.
Gary Blevins, Wilkes County Commissioner.
Mike LaBrose, County Commissioner, Caldwell County.
Stan Kaiser, County Manager, Caldwell.
Michael Gage, County Commissioner, Polk County.
Billy Kennedy, County Commissioner, Watauga County.
Darren Gia, Watauga County Manager.
Phil Carson, Swain County Commissioner.
Judy Poe, Ashe County Commissioner and Smoky Mountain Board member.
William Sands, Ashe County Commissioner.
Greg Cable, Graham County Manager.
Vicki Green, Jackson County Commissioner, Jackson County, that sea of blue and that state of red.
There you go.
Good show, Luke Jackson.
Shelley Foreman, Senior Director of Planning and Public Affairs for Smoky and liaison to this council.
Good evening, everyone. Christina Carter, Chief Operating Officer for Smoky.
And I'm Brian Ingram, CEO at Smoky.
Also has some staff over in Martin.
Go ahead, Mary.
Well, hi, my name is Mary Short. I live in Alexander County in Taylorsville. This is my daughter Katie. She's on the 1915C part of your BC waiver, the Home and Community-Based Waiver, NC Innovations.
Hi, I'm Sean Jones. I'm the Senior Director of Provider Network for Smoky. And that is my phone.
Melissa Isaacs, I work in the finance department here at Smoky.
Fred Day, I'm the Chief Financial Officer here at Smoky.
I'm Ryan Barber, Administrative Assistant.
Thank you. We appreciate that. And Ryan, if you didn't catch all those, we'll look at Jerry's tape later to catch all those names. The second item on the agenda is a review and approval of the agenda itself. If you have your packet, you will see a sheet on the left side. It looks like this. And if anyone would like to make a motion to approve that agenda.
So moved.
There's a motion for Mr. Kennedy from Watauga County. There's a second.
I'll second.
And second, forgive me the name from Rutherford County.
Gene Edwards.
Yancey County. Yancey County. Gene Edwards, Yancey County. Gio.
I'm going to speak up. I'm
Sorry, that's my fault. I should do better with memorizing the names. We have a motion and a second on the floor to approve the agenda. Any discussion? Okay, all in favor of the motion say aye.
Aye.
Any opposed? The ayes have it. The agenda is approved. The next item is prior meeting minutes. Has everyone had a chance to think these were sent to you earlier? Have you had a chance to look at those? If anyone would like to make a motion for approval of those meeting minutes?
So moved.
Motion for Mr. Kennedy. Second. Second from Haywood County. All right, any further discussion? All in favor of approving the prior meeting minutes, say aye. Aye. All opposed? The ayes have it. Those minutes are approved. The next item is new advisory council appointees in December. I think the issue here, and correct me if I'm wrong, Shelley, is that We're aware that some of your counties, because of the election this past week, have commissioners who may be rotating off your board and new members coming on. If you could give us a heads up here as to those of you who may be rotating off or may be coming on, so that we can kind of correct our records and make sure that the appropriate person gets noticed for our future meetings. Is that accurate?
Yes, and what we'll do is, I know that your first meeting in December or your meeting in December, whether it's one meeting or if you have several, you choose one of those meetings where you do a lot of your business for the year. So what we will do is we will send out an email to all the county managers, just letting, for you to let us know if there are any changes in the person who would be appointed to this committee, and then we'll work that out and do orientation for that new member before our next quarterly meeting, so that they will come in having an idea of what we've done in the past for our second meeting. So we'll catch them up on the last two.
Is there anybody that knows tonight that you will have a new person coming on? Yes, sir.
I'll be going off the board.
Okay.
I'll be a new commissioner.
Okay. So Nancy and remember which county?
Rutherford.
Rutherford. Nancy and Rutherford. Any others?
I'll stay on because I just want to let you.
All right.
I got a 4-year term, but we haven't decided who's gonna be on what board yet, so I'll let y'all know as soon as we know, but I'm on it right now, so.
Okay, and then I know, yeah, okay, so I'll
We
check
know
in
at least
after
Rutherford
December.
and Nancy
Right.
need to check in with them. All right. As far as the next item of business, the Performance and Quality Committee requests a member of this council to join the Board of Directors Committee. That committee, Shelley, if you'd like to talk about that.
Well, this is a committee of our board of directors. We have several subcommittees of the board. I am going to, here in a second, ask Christina if she maybe can give you an overview, but it's a committee that has been formed to really take a more in-depth look at all of the quality indicators and performance standards that Smokey has in relation to our contract with the state. During our board meetings, we have a lot of activity that happens, and sometimes we don't have the time to completely go into all of the indicators and the performance standards we have. So the board decided to set a special committee. Julie Sinclair, who is a wonderful person at Smokey, you've all met her. She's our contract manager for the Medicaid waiver and senior director of Program Integrity and Quality. And that committee wanted to invite a member of the County Commissioner Advisory Council to participate. Our board meetings are the 4th Thursday of almost every month, with a few exceptions. And the meeting, I believe, is at 3 o'clock. 3 to 3:30, yeah, 3 o'clock. So I'm going to stop there and maybe let you say a little bit about that. And then what we can decide is if, how we want to take action. Do we want to have volunteers for that? How you would like to decide if that's something that you might be interested in, and how this group could officially nominate a person to represent you on that group, because we would expect for them to come back and report back on the activity that's happening. And Carl, I believe you're on that committee as well.
They have this fortune of appointing me chair.
So maybe you can tell us a little
maybe.
bit more about it.
And probably your maybe personal experience, maybe what the folks tonight would like to hear about. Not putting on the spot. I can say something, but.
Why don't you go ahead and say something,
Okay.
I'll see if there's anything I can add to it.
See if she gets it right.
That's right. You can tell me if I have a job tomorrow or
I'm
not.
always curious myself, and Julie's not here.
So Shelley was just talking about, so I think one of the things the committee, is my understanding, the intent, is that to be responsible to a group of people from the board, and possibly one of you or who's ever interested, so that you know a little bit more about our business. How are we really doing? What are our scores really looking like? What are we required to measure as a managed care organization as well as a local management entity? So it is data, and it's very graphic and things that probably you're used to looking at in your day-to-day jobs. But what it is this, how well is Smokey functioning? How well are we doing? All this information is public information. We're very transparent about it. It goes across our departments and various aspects of it. I think it's a good indicator of what is Smoky Mountain Center. We talk about this all the time in Smoky. How do we describe ourselves? How do you tell somebody what you're doing? So it does look everything from consumers to families to how systems are working, and we trend that data and we talk about it, and we're of course very transparent. The numbers tell the story. We're either doing really good or not too good. So I mean, it can be a little overwhelming. I think it would be fair to say, don't you think, Carl? I mean, you know, this is big business. I mean, just like your business is big business in the county. And we have a responsibility to the board, to you and whatever you want to know, and of course to our consumers and families and providers, to be very transparent in our quality as well as just how well things are working. So,
Is this a board position?
No. We have, this committee is made up, I think there's a member of the Provider Advisory Council that participates.
The board, everybody who's on the committee is a board member.
This would be the only non-board member on the committee. It's important to me as chair. I mean, this is a new committee in a lot of different ways. Look, you think about smoking. I remember talking to Brian. We had some arguments about what it should do, and just something Brian would do about everything. But smoking, you know, it's easy to think of smoking as an insurance company nowadays because it's really just passing through money. But we can't forget that what Smoky really is, it's an agency of 23 counties, because you have the mandate by the legislature to provide mental health services through Smoky. And but to provide services over 23 counties and keep track of it is nightmarish at best, and all, you know, really tough. And the staff does a good job, but these reports, the idea, as I understand it with the reports and what the committee is supposed to do, is help the board understand what are we doing at a service level. Not what services are we providing, that's different. That's what the staff determines and the state determines. But we've got, it helps us measure. And when we tell the state, here's what's going on, part of our role as that committee is to look at these and say, okay, we've got the right mix, we're comparing well to other people, are we missing anything? And we're still developing those reports. They're constantly changing the reports. The stack is a little overwhelming. We don't read reports, because that's what I told Brian we didn't want to do, but we try and help people get an idea that the services that Smoky is providing are consistent with elsewhere in the state, and they're also kind of what we as board members or and hopefully as commissioners feel are important to our area. So it's not an easy one to describe because it's still a product in development, but that's been the role of the committee, is to take us beyond the insurance company focus to the service without talking about specific services.
And I guess I would ask what would be the pleasure of this group if we may have more than one person interested. If there are several people interested, we could, you know, they could nominate themselves and we could bring that back. But I know it's something that, you know, it is a commitment of once a month coming on the fourth Thursday. And, you know, obviously the board meeting is an open meeting, so if you wanted to stay and listen to all the exciting things happening, you could. But it's sort of up to you as a group and how you would like to process that nomination.
Is there anyone here who would like to volunteer to be on that group?
Christina, we do great. We didn't get a single volunteer.
We have, everybody's sort of waiting, I think.
Well, I'm somewhat interested, but it really, I'm just, I've had some issues with the board and the advisory board. So, you know, going on representing the advisory board really is not even getting a vote. So, you know, if this should be, you know, to me, it should be one of those board appointments. But, you know, it's a monthly commitment without a vote is a little frustrating for me. So, but.
Anyone over here who would be interested? Middle? We need that, I mean, it's an opportunity, it really is.
Is this a requirement, or is this just something that would be nice? To have that person on?
We're basically trying to give an extra voice to this.
And to have someone who will come back and report back on the information to you.
One of the concerns some of us on the board feel strongly about is we don't have enough county commissioner representation, because we're an agency of the counties. And this isn't what I think some of us would like, which is to have more commissioners. That's not within our purview, it's not within the board's purview. But it's one extra way to help commissioners have a little more say and a little more input. So if you're willing and you're willing to give, it'd be nice if you could. And that's the way I've kind of looked at it too. But I know it is a commitment. It's when you're not on the board, why do you want to go to a committee meeting? I understand.
You love data.
If you love reports, man, this is the thing you would.
Place for you.
Yeah.
Yes, sir.
Oh, does it have to be a commissioner?
It could be any member of this group.
It'd be great if it could be a commissioner, just because, like I said, and I'm speaking for myself as a board member, I would, as a county manager, I'd love to see more county commissioners on the board. Because this is an agency of the counties. So,
But
that's
everybody
the way-
on that committee is on the board except for this one person.
That's the downside.
Well, what we can do then, since we don't have any volunteers tonight, is if you want to think about it, you decide to change your mind, let Shelley know. I think you emailed all of them, right, so they have your
We'll do
email
a
address.
solicitation again, and probably what I'll do is maybe get to December after your first board meeting, because there are other people who will be on the board, and then you can, or if you just go home tonight and think, gosh, why didn't I volunteer? You can help me.
That sounds great. Okay.
Hope springs eternal.
For the next item, to get into some of the meat of what we're going to be talking about tonight, is smoking funding and service system overview. I'm going to turn that over to Brian Ingram, our director, and he'll cover that. And if you have any questions when he gets finished, he'll be happy to answer those. And I'm going to sit down and get out of the way of the screen here.
Enjoy your cookies.
Yes, and Jerry, you do have Photoshop, right? Because I ate some of that chocolate cookie, and I'm afraid my teeth might have been.
I'll leave it as it is.
Okay.
Well,
And by the way, we had Rick French, our board chair, who's also county manager in Alexander County. Mary Yoder, who's county commissioner, chairman of the Alexander County Board of Commissioners. We're glad you could join us also.
great. Appreciate it, Michael. And thanks for everybody coming out tonight. It's always a challenge to attend these things, and people have busy schedules, so we'll try to make this as helpful and efficient as possible. And if I guess if you're giving out grades for trying, I hope we'd get an A on this next section, because we put a lot of effort into trying to, on the one hand, be very complete in terms of talking about how the money works, and especially how the county funds work. But by the same token, not make it so complex that it would be beyond what we could do in a setting like this. So we'll see how well we hit the target, and as far as that goes, we can make a lot of refinements to this over time. We just kind of had to take a stab at something and see if we were pretty close to the target. Hopefully we are, and if not, we can revisit this. So there we go.
And there is a handout on the left side of your packet that has the slides that we'll be covering.
So the basic stuff first, of course, just simple information about smoking. And probably all of you, if we were going to give you a quiz on these 4 bullets, I'm sure everybody would get an A. 23 counties, we provide no services directly. We're a manager of care. And just as Carl said, much like a public insurance company. And in fact, we were, if you like that description, we have 2 plans that we offer. We have one for individuals that have Medicaid, and then we have another for all the individuals who do not have Medicaid. And we'll talk more about that as we get into it. And of course, organized around a board that's consistent with the general statute. So, Medicaid funds, state and federal funds, single stream, which is a type of state funds. And here's where we're trying to give you a little specificity without going too far. When we talk about state funds, it's that single stream, which is the bulk of it. And by single stream, really in this case, it means that it is not designated for any particular type of care, but it's kind of a blank check, you might say, for care for individuals, again, to pay for services that are delivered by provider agencies that we contract with. It's a way of paying for the care that they deliver to individuals that do not have Medicaid. In the case of Medicaid, they bill us for that. In the case of not having Medicaid, there has to be a way to try to pay for that care, even though that's a very difficult equation. So single stream is the major source of money for that. And in some cases, there are particular programs that are funded by the state. There used to be more, there's fewer now. We'll give some examples of that as we get into it. And then it's also the county, what we call maintenance of effort funds. And in some cases, I think there's just a couple of counties that kind of lump in the ABC funds that are associated with that. So that's the, if we go from 50,000 feet down to, we'll get down to maybe about 5,000 feet, this is how we look from 50,000 feet.
Just as a FYI, while Brian is changing slides, only a handful of counties give us additional funds through the ABC funds. You have your maintenance of effort, which is a set amount. We do have several counties that give us, in addition to that, funds from their ABC board. So just to let you know, that's an opportunity if your ABC board and you as a county would like to, look to Smoky as one of those areas you could designate that as a possibility.
So if we rolled up all the money into a pie, this is what it would look like. And you can see that Medicaid is far and away the largest source of revenue that we have. And again, this pie represents service funds. Okay, now there's some, a couple of exceptions here and there that we just kind of eliminated, but this is, a really good representation of the amount of money and the sources of money we have to pay for services. Okay?
This does not include costs of employees and administrators.
No. So that's, and I don't know, is this what you would have thought about us as an organization? People recognize how much of, what we do is based on Medicaid. I mean, which really kind of gets us into one of the biggest challenges we have is the disproportionate relationship between how much money we have for care to individuals that do not have Medicaid. That amount of money compared to the amount of people that need care, that is a much more difficult equation to make work compared to Medicaid. By and large, there's a lot more Medicaid funds available for individuals that have Medicaid and need care. Yes, sir.
Do you have any figures on what that would have been, that Medicaid portion of your total service revenue would have been had they done the Medicaid expansion?
Well, we could, we could model it, okay? And let me, that question leads to another kind of explanation. How does that Medicaid money come to us? Okay? In a way, and again, if you want to stick with the insurance company way of thinking about it, there's a premium payment that we are given each month that is called the per member per month. Okay, and by that, that is to say that there's a calculation for how many individuals are eligible for Medicaid that month, and it is multiplied by the type of eligibility within Medicaid that they have. Okay, so there's a handful of eligibility categories in Medicaid, and for AFDC, let's say, we're paid, and I'm just going to make this up. I don't know the exact number. We're paid $6.43 for every individual who has Medicaid eligibility under AFDC. Okay, so however many of those individuals there were that month, we get paid that number times that amount. And that occurs for each of those eligibility categories. So that's how it works. Okay, so for us, under an expansion scenario, we would have to, we would look at how other states, how the enrollment worked in other states. In other words, what type of eligibility categories under expansion did people come in under? And we could probably get some idea of that and then just do the math and add it to the equation. I think, statewide, we're looking at what, 600, 500, 600,000 people, new people that would be eligible for Medicaid. So they give you some idea of, in the scope of it. We're, there are 9 MCOs, we're one of the larger ones. You could get pretty close to figuring out what that would be. We just, haven't done that. Any other questions?
Well, if you're serving 900,000 people in our catchment area, and Medicaid 600,000 people, it'd be like 2/3 of that, if it's the same thing. So you'd be talking another 100 million or more, roughly, in the ballpark.
If we ended up with the same ratio of individuals for,
Sure.
in broad brush, yeah. Any other questions on this? Okay, and just naturally by going through this, because you asked such good questions, we got to talk about how the PMPM works. And again, that capitation is done on a yearly basis. And it has to be actuarially certified to be sound. So in other words, we go and we meet with the state, and they have their consultants from Mercer come and try to come up with what they believe is going to be an accurate rate for us. Now, all of this is about the state not having risk for Medicaid payments, right? So it's some certain. When our rate is set, that's how much we're going to get. So they can write that on a line, in the state budget. There's going to be any more Medicaid expense for all the services that we're responsible for covering. And that, there's a lot of things that go into the calculation of that rate. Not the least of which is bending the Medicaid cost curve. And, again, it's been difficult for us to calculate because of our particular experience with, starting with the original Smoky and then adding in the legacy Western Highlands counties. But in 2 years, I think ballpark, we've probably saved around $20 million. Again, just as a function of that capitation. Changes that the state makes in terms of expenses that we have to manage by essentially our managed care functions. Fixed monthly payment, right? 6 Medicaid categories, and a very important feature of the Medicaid program, and I know you all understand this, but you think about the differences between our two plans. If you have Medicaid, that's an entitlement, right? It's means tested. You all understand how that works. Anyone who has Medicaid is entitled to receive services if they have what's called medical necessity for care. And that's the way it works. It's an entitlement. Now, you can, I'm sure, appreciate that there can't be an unlimited amount of care. On the one hand, you're entitled to the care, but yet there is not an unlimited amount of money to pay for that care. So the challenge, of course, being for us to deliver that care in a way that meets the entitlement for care, but yet delivers it in a way which is going to be most effective clinically and within a certain capitation or budget. So that's the challenge.
Brian?
Yes.
When I'm sending you, unfortunately, you do not have the version with the disclaimers. I so apologize, and I'm sending it to you right now.
Okay. State and federal funding. Here, the big difference for state funds has to do with the fact that there is no entitlement to services, okay? It's really the language that's used around that, and I think maybe that's in the other slide, has to do with, doing, I'm going to say the best that we can. If the language in the general statute is something to the effect of, given the amount of funds that are available. So it's a very different situation between, again, the Medicaid program and those individuals that do not have Medicaid. So maybe what I need to do is to just switch to the other slide set?
I would appreciate it, and I apologize, that was,
Okay.
that was on Shelley. But we're right in order, we're fine now. I just held it to you. I'm so sorry. And the information that we're alluding to is in your packet, and it's what we air quotes the disclaimer. So after you hear a little bit about our funding and how we're funded and what that means, there are some caveats we want to talk to you about as far as how we look at our funding as a total when it comes to especially state and local funds.
Probably asking yourself, what kind of presentation is this that the first slide is all the disclaimers? Well, it's a very honest one. To try to give you a global financial picture is, we can do a good job with that. But as we try to slice that down into how the money is spent, based on certain categories, it gets more and more, the harder we try to squeeze that, the more imprecise it gets, is what I'm going to tell you. Now, that did not stop us from trying to do that, and that's what we've done. But as we go through this, these are some really important things that you're going to have to remember as we talk about, especially how the county maintenance of effort funds are used. Because it is not as if we have complete specificity around where those dollars go. They go into a pot, essentially, of care for individuals. And we'll talk more about that as we go through. In some cases, we know more or less about how that exact dollar that you're giving us is being spent. So, to begin with, the fiscal year, and the pie chart that I showed you, choosing the descriptor about a particular client that receives services. Just in the crisis services report that we're doing, we're choosing, we can't show that around county of residence. Okay, you can have you can have a county of eligibility that's different than where you actually live. Of course, if you understand, how the Medicaid works, that's just one of those features. People can be represented in more than one category. And of course, because of Western Highland, we have certain limitations around the availability of that data and how we can show it. Fee-for-service and shadow claims. If I was to use the term fee-for-service, would people understand what that meant? That's kind of like the retail part of things, okay? Where a reimbursement is given as a result of a particular service that's done for an individual. So a fee is provided to the provider based on that particular service. Shadow claims are another way that we keep track of how individual clients are served, but the reimbursement does not occur as a result of that. For example, we may give a provider $50,000 to do a service. They'll receive that money, and then we'll get information back to them as that money is allocated around how many people were served. So can we tie each dollar to each individual that's served? No, but in a global manner, we can understand that. There's a whole other category of funding that is called expenditure or invoice, and Melissa Isaacs gave us a great description of that. But basically, that's a payment that we make. It's almost like a subsidy. You know, we know that certain services, and I'll use psychiatry as an example, it doesn't pay for itself. So what we do is we underwrite that service, not based on particular clients that are served. We just make a blanket payment so that the service can be delivered. We don't want to hamstring the provider to have to bill an extra amount for each individual. So we can do that in a couple of ways. Expenditure is just based on the expenses that the provider has, or invoices is similar to that. Did I do a pretty good job, Melissa?
You did.
Okay. Any corrections you might like to make?
No, it's just when you're going through this disclaimers, that's one reason we can't capture every consumer that's served in each age disability areas, because when we get invoices or a report of expenditures, it might not have, you know, the number of consumers that was served with that $50,000. So that's why we were wanting to disclaim that when we're giving counts on anything, it's only for those services that have a direct claim associated with them.
A typical service here would be, for example, substance abuse prevention services. You're paying an employee to provide a presentation to a group. Well, we're not keeping track of each individual within that group, but the service availability is an expense associated with that. So most, actually, prevention services are funded on an invoice kind of basis.
These last two bullets are by far and away the most important to understanding the limitations here. And this is not something particular to Smokey. This is just how this works in the system. Essentially, state money, again, single stream, and in some cases that specialty, specially designated care, and county money, it goes into a pool that is available to reimburse providers who deliver care to individuals who do not have Medicaid. It is just that simple. And that money is used throughout the 23 counties. Okay? There is some kind of, within regions, there are some ways that we kind of isolate amounts of it, but by and large, it is a pool of funding that we make available to providers to reimburse them for the care for individuals who do not have insurance. Okay, and really more and more, we used to use the term indigent, which is probably not the best category. It's individuals who are uninsured or underinsured. Many people have insurance, but the insurance plan does not pay for what they want or need. So we get into a position of trying to help the provider cover those costs as well. And that's just really a fundamental piece of business here. So I want to make sure everybody understands how this works. And then the last one, and there's some good examples I'm sure folks can give around this. Every service isn't based on a county. You know, there are services for which there are no offices, essentially. You know, they're delivered out in the community. So to try to isolate the funding that's associated with that program to a county, it really just doesn't work that way. And I guess what you have to, reflect on is that really each of you are part of a 23 county health plan. I mean, that's the best way to describe what it is. And that collectively, you're able to leverage a lot more funds. You can go back and look at that Medicaid pie. That money helps to underwrite care for a lot of folks that if you were just doing it as individual counties, you couldn't leverage as much funding, you couldn't drive as much care to be delivered. So that's kind of the upside to it. And of course, all of public policy in North Carolina has been scaling this to some larger amount. And in our case, it's 23 counties and a budget of about $350 million. And our job is to maximize, is to take that money and to maximize the benefit to consumers based on their particular categories. You know, and again, essentially, it's a big fork in the road between Medicaid and not Medicaid. So let me just stop there. That's a big part of understanding that will help you understand, you know, the rest of it as we start to really go through and talk about particular services. So keep that chart handy, okay? Just a little bit more about maintenance of effort. And again, there's a piece in the general statute around how this is intended to work. And it's kind of the amount that you have in, you know, should continue to be the amount that you contribute, barring some particular features. And you know, this is at times when we've talked about this in our board meetings, that, you know, whenever you start trying to compare this across the state and among counties, you know, it never goes very well because it's all over the place. Well, there is no per capita formula for how much counties should give. There isn't. It's all just a historical practice that you know, counties have taken whatever position for whatever reason, you know, they've decided to with it. But just for context, the range across the state, you know, there's 9 MCOs, is between $2.82 and $27.30. That's per capita. Okay, so if you take the total amount of county money divided by the number of in general population, that's what you come up with. And the statewide average is $9.56.
Just one key thing you said there that they may not have caught is that that's the per capita range within the LMEs and MCOs, not by county. Because within our own catchment area, we have counties that are paying less than $2.82.
Right.
And then there are counties on the other end. Mecklenburg, for example, at one point was $60-something per capita, I believe.
Well, if you want me to...
I was just pointing out that that's not county per capita, that's LME MCO per capita.
Correct. Where do you think we are in that?
That is good.
We're the 282. Okay? So is that a good thing? Is that a bad thing? That's just a thing. Okay? Does it have a big effect on how much care can be delivered? It has a big effect on how much care can be delivered. Again, regardless of how much we have to work with, you know, our job is still the same. It just changes based on the amount of funds. So it's just a little perspective, you know, and there's no, I mean, and again, it's just the way it is. And again, as Shelley said, the ABC funds, I think there's just a couple of counties that roll that up and send that to us as well. Okay.
This is in your packet, it's easier for you to read too.
Yeah, and again, we don't, you know, you can, this is the kind of thing you can kind of look at. Again, trying to give you some perspective on your county, its size, the number of individuals that have Medicaid versus those that are uninsured. Now, I will tell you that the definition for uninsured, you know, when I look at this, I think those numbers are suppressed. I don't know the particulars. Did this come out of the Shep Center, or what was the source for this?
Let me put my reading glasses on.
All right.
That was the state management budget.
Yeah. You know, I don't know how they determine if someone in your county is uninsured. But, you know, really, if you remember the way I talked about this, it's not only the uninsured, it's the underinsured. And maybe you double that number, okay? And again, those would be all the individuals that we would have a responsibility to provide service to the extent that we have financial resources to do that.
And just to really even strengthen what Brian said, I think the uninsured numbers, because they are more ambiguous, they are gathered at the time of census through the demographic and population, and they're sort of projected from there. So it's unlike Medicaid, where we can actually, physically determine how many people are enrolled in Medicaid. Indigent is based on the population and will grow in between census time.
Well, remember the disclaimer I gave you, the deeper we dive into this, okay, now we're trying to just look at MOE funds. So we've isolated them away from the state funds, okay, and the federal funds. But remember, I've told you, they're in that same pot. But we've tried to just pull them away and talk about the services where we dedicate those funds. And we've done that by region. Again, to give you the best possible view of how we use your funds and to some degree state funds as well. So, again, the easiest one, there's always three, and especially in more of our historic counties and regions, psychiatry is very expensive. But yet, medical care, we kind of think of that's like the Alamo. That's the thing that has to be there. We have to have that for people, and we have to find a way to pay for it. So we use, we really prioritize that care and use funds to support that. Just like walk-in crisis care that we have available essentially in every county. Billy.
So how do you decide, do you split that money up by per capita or by region? How do you balance that out over the whole 23 county catchment area?
It's based on our contracting with providers, our comprehensive care centers.
And so if there's not that provider in a county, they don't get that part of the pie.
They are, but there are those in each county. And again, that's kind of our, what this forces us to do is to prioritize. Okay, there isn't enough money for everything. Just, that's the same world right, in your county.
Yep.
So what do? You have to pick the things you're going to do. And you pick the things that are going to be most important from a care perspective to individuals. And that's what we do. And again, the case for this money, okay, your money and the state funds is, that is extremely precious. Again, because the ratio of how much of that there is to the individuals that need care, it's way out of whack. Way out of whack compared to Medicaid. So we have to make very, very hard decisions around how to spend that money. And we also have to put our eggs in one basket. Because if let's say we wanted to have just one agency that all they did was indigent care. We were going to give them all the money, okay? They'd go broke in about a month. It just wouldn't work that way. The only way we can do that is to take an agency that has a fairly large infrastructure, makes a lot of money on Medicaid, has a healthy revenue stream based on the Medicaid program, because remember that pie? That's where all the money is. So that they can then do as much as possible of the other care, even though we know we're going to underfund that. It's a crazy business deal, isn't it?
Sure, and so things like group plans instead of individual services, this is the kind of thing you're having to do, because instead of basing the distribution on need, they're setting a fixed amount and you're having to fit your need to that fixed amount.
Basically. But there isn't any other way to do it. We do the best we can with it. So again, we limit the number of providers that we're going to give that money to. Because of this, the only way you can hope to address it is to scale it in the largest fashion you can that is reasonable. And you have to have a provider that has a good revenue stream with other services, not care to the indigent, to be able to sustain all of that. Basically, what you're doing is you're paying for all of their infrastructure with Medicaid. Right?
The other thing that Brian's not saying that we've learned over time, and those of you who are on the board know this, is that at that point in time where we didn't pool it all with these comprehensive providers, you had a certain array of services that everybody wanted to do because they provided a lot of money, and that's where you saw a lot of problems at the state level because there was misuse of those funds. But then there were other services where there wasn't enough money to do the service, and nobody wanted to do them. So you had even less ability to provide the service because no provider would step up. And you had those who would step up only taking the diamond,
Good stuff.
the good stuff. And so by doing it with a comprehensive provider, saying, yes, we're going to give you some of this great money from Medicaid, but you've also got to provide these things that are going to lose money.
Yeah, take all comers.
Now,
Brian?
yes, Judy.
What you're saying about, just say for example, northern region,
Mm-hmm.
the 817,000, I'm assuming that is from the MOE money from 5 counties,
Correct.
correct? Okay, that money is totally give to Daymark, and Daymark is the one that picks the programs that they're gonna have in each county,
We tell them what programs they have in each county.
okay?
That's part of the contracting process. Okay, and
But it
again,
is programs that Daymark's gonna use in these 5 counties,
that's correct.
okay?
Now, let me be a devil's advocate. Do we know that of all of those programs in those counties, do people from other counties go and use those services? Sure they do. Right? You know, again, because you're part of a 23 county health plan. So it's that pooling effect. But, you know, by and large, are the majority of the folks that are served by Daymark residents of that county? Yeah, they are. Can we tell you every single one? No, we can't. Okay, because of all of those reasons. But this is a good broad brush. We're just not trying to, we're just being very honest about the way it works.
Where does Meridian fit in this western region?
Let's go to the western region. They receive some of the, let's see, to some extent, the state and county funds that go to care for the indigent.
Okay.
They get a good hunk of that money. And I think, and help me out here now, I think, we're getting a little bit ahead of ourselves, but you're asking a good question.
Well, thank you.
Brilliant as always. I think we've given some regional information to you, based on your region, that shows the provider and the funding that they receive. So, you could go and look up Meridian, how much did they get, for example. Okay?
Yeah, the county manager just assisted me in the fund.
Okay.
Yeah, in your packet, it has for every region a list of the providers funded through state funds and a little bit about Medicaid and mobile crisis services, as well as use of facility-based crisis. So you can get a snapshot for each region.
I can tell you, just because I know that neck of the woods pretty good, Meridian, the funds they get that are in that pool goes to fund the recovery education centers. And a little bit probably if they do a little psychiatry as part of that too.
Okay. Thank you.
Do you give money to, like in our region, I've lost it, but I think we get, does it all go through Daymark and then they pay these other providers, or do you?
Daymark doesn't pay any other providers. We're the only ones that contract with providers and reimburse them.
So even though you limit the number, you still got page after page of bunches of, that's a lot of providers, isn't it?
Those are, that's, the list of,
That's.
In the northern region?
Because we have other services other than mental health, and behavioral health
The
services.
lion's share of it's going to them. If
Right.
you look at the
Yeah, oh, yeah.
portion.
But you can look at,
52%.
yeah, we wanted you to see that there were other providers in the
Yeah.
community and that there are services for individuals with intellectual and developmental disabilities that fall outside of this, so it helps give you a snapshot.
Now, is that, just tell me, is that state and county funds?
Yes, it is.
Yes.
Okay, so hang on a second.
That's everything.
That's
Federal,
state and
federal,
county
and local.
funds.
State, federal, and local, all three.
So that's the whole package. And again, could we come up with some list and say, oh my gosh, we only give the county funds to these agencies? I mean, we could try to. Would it be accurate? No, it really wouldn't, because we can't do that. And again, you go back and look at the way the money works. It's just, it's not designed that way.
So how does that work when like a county reduces, I know, like I said, there's only certain circumstances that you can reduce your maintenance and effort. Because obviously, we cut some money, the county, Watauga did, and basically we heard from Smokey like, oh, you affected our service. The question I got is, how can they say that if you're saying the money's pooled and then you kind of determine what services they can or can't provide?
The other 22 counties helped you out.
And for these services, we only have, when you look at state and federal and local funds, that still is a small amount of our budget. So when money is removed, there's only, you're taking money away. And it's just one of the things the other counties have helped you out, and it does impact for providers, what they can do.
It's equalized by the other counties is the truth of it, and we've had some terribly difficult discussions, Darren, around situations where counties have made radical changes in their funding, and, I just have a chance to defer to the board in these cases. Well, shall we just eliminate services in that county? Is that what we should do? Or should we let the pool fill in around behind it, which is what happens in other cases where there's reduction? They're just, there isn't a good place to go.
Well, like you said, because there's other variables to that, and the fact that, if you look at like Watauga and Wilkes and things like that, they were funding high levels when we had New River and things like that, versus like, again, we talked about the other counties, and again, I know you said hard to compare the other counties, but again, when you say we reduce it and they kind of picked up for us, but I guess you can make the same argument that we were picking up before with the amount of money. Especially when I look at the one region, it's $200,000. And Watauga was given $221,000. So
And as you spoke, that arbitrariness of that standard that was set just at one time, depending on what counties were doing. So that should be tweaked somehow. But in the pool, I assume y'all are tweaking that. So
We decided, we don't,
Nobody will go home happy if we keep going down this road.
But just as a FYI, maintenance of effort has not been raised in how many years? Counties, the amounts we get for maintenance of effort are basically been for most of our counties have been set over long periods of time, and there's never been any real tie to what you give versus what you get or what's needed, I guess would be fair to say, or the average per county.
yeah, they were locked in before you guys voted out.
Hey, Brian, my observation, and I don't know a lot about the Smoky, but I've been a commissioner for 6 years. And I don't know what discussions you had with the legislature, but when they changed the structure and took the commissioners off the board, and for practical reasons because of the size, if you've got 23 counties with 5 commissioners each, that's 115 commissioners. I guarantee you there aren't more than a few that even know anything about this. But yet, I could go over there and advocate for you to get more money, and I'd have 3 or 4 commissioners vote against me simply because there is no structure for how much money we have to give, and they're not going to spend money they don't have to spend.
You stole Billy Kennedy's sermon.
That's just the way it works. So
that's a county decision.
And you can't make a decision based on not being involved in knowing what's going on. So I'm just advocating for why it is where it is, as far as what's going on in the commissioners' minds, because I've seen it. So an education program to get everybody up to speed to understand what's going on would be helpful. And the more commissioners you eliminate from that process, the worse it's gonna get.
Well,
Unless the legislature, wants to dictate or have a statute that describes exactly how much per capita or per service, event you're gonna have to get.
I don't expect they're gonna come up with that.
No. They're too busy with other stuff.
Well, it's not just that, they don't want to tackle that when they know, for example, if you look at that $2.82 to $27.30 range, and the reality is, it's really more varied than that, because the county is who you'd be talking about with MOE, and that range is more like, what, buck to about 75 or 80 bucks. And so what legislature is going to put forward a piece of legislation that says, okay, we're going to equalize it. We're going to say $25 across the board. That means every county that was paying $1 or $2 or $3 is going to be mattering all get out.
But they don't have to do that.
And all of the MCOs that were getting money from the counties above $25 will be screaming because they just lost a significant amount of revenue. So, Brian's right. It's not going to happen.
Well, it's going to cost more in some counties than others, and that's fine to do some kind of formula. I mean, it does cost more in some for people in some counties than others, but not to have any basis for this.
I would agree to it if they give us our lottery money back.
Hey, Brian, part of the issues you face as an executive director of the staff, you talk about this is, kind of broader use money, is that if you don't tie it back to the individual counties, then there won't be the incentive for the counties to increase it. I think that's that's different from the discussion we were having, but I think that's going to be a fundamental thing that Smoky staff is going to face if they ask for more MOE money. Because there's no, I can't see where, we do $102,000 in something or other. It's a nominal amount for the level of service we receive in Rutherford County through Smoky services. But if you don't tell me what that next dollar is going to go towards, it's hard for the Board of Commissioners to vote for it. And I'm not saying what we're doing is wrong. I've had a lot of discussion about this. But I think you've got a built-in structural problem to ever increasing MOEs. And if there's not a mandate, I don't see it likely to increase.
Well, Carl, do you think it'd be a good example, and I keep using the northern because that's what I'm familiar with, but the 5 counties sit down, the 5 commissioners on each board sit down with Daymark, let Daymark say, okay, this is what we're spending the money on, this is how many people we're helping in your counties. So you think that would help for each county's, each group to do that? Would that
No, I can only speak to Rutherford. I don't think it would. If we went to FPS, because the need for our MOE money traditionally in the Western Highlands group in Rutherford County was gap money. The MOE money was used for service gaps, and so it was used for a whole different purpose. So in our case, the fact that it goes to FPS is really not of great benefit. If it would go to some other things that fill the gap that FPS is not providing. But I think the compromise that Christina and Brian came up with has worked, very well for Rutherford County. They've leveraged our money many times over, but I don't see that there's where if they don't show the extra dollar. I mean, I can only speak to our county. I don't see how it would help. I'm sorry. It may just be because we're Rutherford or because we're Western Highlands Legacy County. I'm not sure.
I mean, the dynamic isn't especially different for anyone. I mean, we're kind of, we're all in this together, really, when it comes to this. There isn't, Smoky doesn't have anything to do with the maintenance of effort. I mean, that's a county by county decision. It's just like, how much do you decide to spend on your roads or, any part of your budget?
Sorry, Brian, don't say that. We don't talk about that.
It's a line item in your budget. You decide based on all the reasons that are important to people, how much money to spend. And it's the same thing. In this case, you happen to be in a pool with others. And it really, not by yourself. If you go away with anything tonight, remember, all in all, that really works vastly to your benefit. You're part of a $350 million plan that if it was if you were each individual counties trying to do a county mental health department, it wouldn't work. But anyway, what we do, so here's where the managed care part of this comes in about the comprehensive care centers. And you each have those in your counties, each of the regions. In the west, it's primarily Appalachian, but to a certain degree Meridian. In the north, it's Daymar. And in the central region, it's RHA. And in the Legacy Western Highlands region, it's primarily RHA and a little bit of Family Preservation Services. We really try to get the greatest economy of scale out of those service dollars and leverage, the greatest amount of care based on those dollars. That's it. That's what we do. And that's in the relationship that we have with the providers and the contract, the service array. Just as Michael was saying, certain services are going to be more profitable than others. And those are the Medicaid services, okay? So why wouldn't we have those services be associated with an agency that's then doing the indigent care, right? Because that's going to help their bottom line to be able to do as much as possible for those things that we know they're underfunding them to do. So all of that is part of the balancing that we do in this model. And that involves saying no to agencies, okay? No, we're not going to contract with you to do this. Or yes, we are going to contract with you over here to do that. That's when they talk about a closed network, it is our decision around who we contract with, because we have to employ these features, if you will, around how we're going to spend the money, which particular services and which agencies. Because before, it was a free-for-all. Michael gave a perfect example. Community support that cost the state, what, $900 million? Did anybody get any better out of all of that spending? I'm not even sure they did. It was just an unmanaged system where providers, and I'm not blaming providers, the system allowed that to happen. Providers set up care that was able to exist in fee-for-service with no management of it. And that's what you have in an unmanaged system. The other side of that is what we have, where you're chosen to be a provider or not. The services that you deliver are part of our contract and part of our network development plan. So it's saying out loud that there's a limited amount of money, and we're going to make hard decisions around how it's spent.
In defense of Smoky too, I look at it in terms of that MOE, kind of like the county. If I said to Rick French in Alexander County, if I were, say a group of citizens from this county that lived in a big development, kind of bombarded county commissioner meeting one night and said, we're sick and tired of you not telling us, or you not providing us services. Tell me where the tax dollars from our neighborhood are being spent. Can you define, so much of that was spent on the paper that we're writing, so much was spent on the software. You can't define some of those things without raising the taxes and hiring some more bean counters. There's some things that you just can't do that on. And the reality is, flip side of that, if you told them exactly where it was spent, it's not going to necessarily, if you said, okay, we can do this much more if you'll give us this much more money, nobody wants to pay that extra money. And I don't think if you told them exactly where you're going to spend it, that they're going to fork over another $15 per capita. It's just what it is. But sorry, I didn't mean to.
All right.
But in defense of Smoky, I don't think we can expect them to account for every.
It's what it is. It's what it is, and we're just being absolutely transparent around what we can say about how the money is used and being very clear about why we can't say more. So anyway, the Comprehensive Care Center is the best approach from a network development aspect to leverage the maximum amount of care. And again, the downside of that is there isn't going to be, it limits the number of providers and is very selective around what they provide. And this is just kind of a list of the things that go with being a comprehensive care center. By and large, and this isn't true for each one, but again, broad brush, open access, walk-in assessment, psychiatry. We try to be as open as possible around crisis management. So most of these organizations also have mobile crisis, and in the case of facility-based crisis, some of them also have that. So we're trying to get them to manage the entire front end of the system.
You got one of these in each county or each region?
There is, these services, well, we could kind of go through. In each of the regions, there is at least one comprehensive care center. The majority of these services are available in each county. Now, of course, do we have a facility-based crisis program in every county? No. No. I mean, some services, again, and it kind of goes back to that same thing. Some services are regional. I mean, just like your health care, right? We're just like that. I mean, we are that. Where some services are only going to be available on a regional basis versus, primary care. Every county has primary care in it. Every county doesn't have open heart surgery, or fill in the blank, same thing. It's scale.
Yeah, I didn't mean that as a criticism, I was just asking the question.
So, I think we covered a lot, and there's more where that came from in terms of the specific information about your regions. I mean, there's so much detail in there that it's really not amenable to going through in a format like that, but I certainly want to provide that to you. Again, this as the backdrop to help you be able to interpret, that more detailed information as part of your packets. And again, that's just, we kind of did it by region because that made the most sense.
I actually would have looked at this if you had emailed it out earlier and been better prepared for this meeting. And that's saying a lot for me. I would have looked at it ahead of time, but that would have helped.
Sure. I'll be sure to do that next time.
As we do regular board things.
Vicki, what did you say? I'm sorry. We wanted to get that for the minutes.
I said that it would have been helpful for me if I'd had this information emailed to me ahead of time, so that I would have had the opportunity to look at it before this meeting, and I wouldn't have looked at it.
You would have.
And did you mail some packets and some not?
Did
When
we
you get your
mail?
packet?
No. We brought them here tonight.
But the one I was looking at on the way down, you had gotten.
That was from the previous meeting,
Oh, that was
probably,
the previous
plus the
meeting,
agenda.
okay.
We can definitely, this was sort of, we could definitely, if you want information emailed ahead of time. Do we do that with the board now?
Well, the board got a packet every month before we started, so I had time
Yeah,
to
we
read it
used to
before I came
mail,
to the
but-
meeting. Whether it was on email or in paper, doesn't matter to me.
So-
But it is handy.
So either mailed, we can mail it to you,
Yeah.
or electronically.
Right, either one's
Okay.
fine with me.
Okay, so
That way
we
we
will
can-
do one or the other, and what we'll probably do is, like I said, we'll have names and addresses and updates for the next meeting. So, right. And we'll get you an updated list of all your members.
And I wasn't able to attend the
Ryan
previous
says we'll make
meeting,
sure
so
that
I'm
we
sorry.
do that for the next meeting. Apologize for that oversight. And I didn't even think about it because I had seen these in advance being enrolled.
We should just do that. Yeah, you're right, Vicki.
He'll take care of that for the next meeting. Are there any questions of Brian or other staff members for tonight? I know that your time is valuable. We don't want to extend our service. Any questions?
Have you had any more communication with the state? Are you interacting with this legislature on an ongoing basis?
Oh, yeah. Yeah.
You want to tell us about that, or?
Well, oh my goodness sakes.
Does anybody want to hear that? Billy?
I mean, there's a lot, it's a very volatile environment we're in. Really just
Well, it hadn't changed in the last two, I mean, it's been volatile for as long as I've been on this board.
And it'll, I think it'll continue to be. I think, once the long session starts up, a major agenda item will be, healthcare reform and Medicaid reform. And, that's right in our wheelhouse. You probably noticed that. So how is that going to affect us? And since I don't think you want to stay for another couple hours, I'll probably.
Well, Ronnie's the chair, Ronnie Beal's now the chair of the County Commissioner Association of the state, and he's on the board here, so hopefully you'll be representing us well at the state level
He
too.
does a very good job at that.
Section 4 of the next meeting for the commissioners, whatever that might be, is this discussion about the role of the partnership with the ACO and things like that. It's going to affect all the counties. It might be a good thing for this group to learn more about, because that's going to be probably the hot topic affecting this and rural health care in the coming legislature.
I think that's a good suggestion, Carl.
And do we have a date yet for our next meeting? Can you remind me what that is?
I didn't hear.
Can you remind me the date for the next meeting?
I will have to look into the next meeting. It's February. It's in your packet. Thursday, February 5th.
Thursday, February 5th. Same time at the same
The
location.
meeting we'll send you information, yes. It will be the same location, and the meeting will start at the same time.
All right.
If there's nothing else,
Thank you.
we'll stand adjourned.
If you will, if your drinks, if you'll throw them away, and the trash is on your way out, please.
Next week, Monday? Or senior sport?
Our county